بسم الله الرحمن الرحيم. على بركة الله نبتدي الويبينار ده. On behalf of myself, Dr. Saeed Qattan, and I wish to welcome everybody join this webinar. Today, this webinar will be addressing the specific case with the intra and post-operative penile prosthesis insertion. We are honored that today we have two guest speaker, Professor David Ryan from UK and Professor Osama Shair from Egypt. Of course, both of them are very well known in the field of andrology, both in Europe and in Africa. Today, my co-moderator is Dr. Professor Naf Al-Hazzal, our prestigious consultant at King Faisal and the head of the Saudi Andrology Group. Without taking further time, we'll just proceed with the case. Today, we are delighted to have 22 debaters to discuss around 17 cases. I wish to go quickly on the names. They are very prestigious debaters. We wish to thank them for the time they give to join us and to enlighten us speeches. First of all, I would like to thank our two fellows, Dr. Shahid Al-Sahibani and Dr. Hamid Al-Ali, that had prepared that would make a lot of effort in preparing the cases and preparing the text. We thank them all. And I'll go quick without sequence, and for all the panelists, for all the debaters, I'll go by sequence. I would say Dr. Shadid Ashur, Dr. Ahmad Rajah from Medina, Dr. Saad Milha, and Dr. Merdawi, and Dr. Abdullah Al-Khayal, and Professor Saleh bin Saleh, Dr. Aziz Ba'azim, Dr. Muhammad Habous, Dr. Maher Muazzin, Dr. Muhannad Al-Harbi, Dr. Hamid Al from United States, Dr. Talal Merdad, Dr. Raed Mania, Dr. Adil Al-Daid, Dr. Abdul Karim Jibran, Dr. Ma'in Al-Bakri, Dr. Abdullah Al-Fakhri, Dr. Khalid Al-Rabia, Dr. Majid Al-Sibaiti, and Dr. Fahd Al-Mashad. I wish to thank them all, and we'll start with our first case. Our first case will be debated by Professor Shadid Ashur from Jeddah and Dr. Ahmad Rajah from Medina. Case number one is on the screen. Case one is 54. We try to make the case all live and true. These are true cases that we have confronted in our practice, and I'm sure everybody has seen it as long as they are in that practice. He's a diabetic 50-year-old male patient who had not responded to any treatment, and he had been undergoing inflatable penile prosthesis insertion. Procedure was going well, but however, after we dilated the first corpora and upon irrigation of the corpora with the antibiotic solution, we've seen this picture, that we've seen the irrigating fluid coming by the urethral castor in the field. We'll start with Dr. Ahmad Rajah to start, or let's with Dr. Shadid Ashur, and then with Dr. Ahmad Rajah. Professor Shadid. It's time for Professor Shadid, Dr. Ahmad Rajah to come to the screen now.
Assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
You can hear me?
Yeah.
We need the picture.
Actually, Dr. Saeed and all our speakers and moderators, thank you very much. Classical teaching is to terminate the procedure, but actually, because of the controversies for this patient, if before surgery, urine and culture and the glycosylated hemoglobin is okay, I will put a dilator in the side that is dilated, and I will continue the other side, putting another bigger caliber catheter, not allowing for leakage around, and I will continue the procedure and continue strict antibiotics for longer duration with follow-up. Other alternative is to do diversion and suprapubic cystostomy if the injury is that big that cannot allow for the first option that I said.
So I don't know if the Professor, can you summarize again? you say two options. You say what you're going to do. This is debate. This case. We know there are a lot of options. They say this case in that condition. You said I can stop or abort. What you're going to do exactly? What in that scenario? What you're going to do?
I will continue for this patient if his urine is sterile before surgery and glycosylated hemoglobin is okay, less than 8. Then I will continue putting one dilator on the side dilated and continue the other side and change the catheter to a bigger catheter that allow no leakage around, and I will follow up.
Okay, so we are going to proceed. I can a small question. Are you going to put again? You're going to go through the inflatable prosthesis, or you change the type of prosthesis?
It's better to change if we have this chance. It's better to change. It's better to change to a shorter duration procedure and no multiple pieces to allow for extension and higher chance infection.
Okay. Dr. Ahmad Rajah, Dr. Mahmoud, we don't see the picture of the debater, please. Can you make sure that the debater's picture appear on the screen, please?
Prof. Saeed, the debater, all debater can open his camera. It is requested, like you see now, Dr. Prof. Shadid Ashur. Any debater, okay, when he talks, he can open his camera.
Okay. Dr. Ahmad Rajah, you would like to open your camera and to come. Dr. Talal, can you open the camera only when you have the Dr. Ahmad Rajah, are you around? Dr. Ahmad?
Dr. Ahmad is here, but he's closed his microphone.
Unmute yourself, Ahmad. Unmute yourself.
Dr. Ahmad Rajah? Okay. Well, we'll have to Ahmad. Okay, can Dr. we have Dr. Yeah.
لحظة, he's with me on the phone, Prof, and he says that you have to unmute me. Mahmoud, can you unmute Dr. Ahmad Rajah?
Okay, doctor. Dr. Ahmad Rajah is here and his microphone is open now.
Hello, can you hear me right now?
Yes, Ahmad. Yeah. Fadl, Ahmad.
Okay, so I think the camera is not working. I tried to access it. Anyway, okay, for this situation, actually my decision depends on the structure, location, and size. So I would like to do cystoscopy for this patient if I cannot see the urethral injury during the intraoperative field, which is venous scrotal in this situation. If it is proximal urethral injury at site of venous scrotal incision, and we have a patient with a low risk, I would like to repair it in a 2-layer. The anatomy is well demarcated on this place. So separate all layers and repair it in 2-layer with absorbable suture. I would like to put suprapubic catheter to be there for 2 months. Urethral catheter insertion for a short time period, 3 to 5 days, then I would like to remove it. And I'm going to proceed for prosthesis implantation, either semi-rigid or inflatable. And this patient needs to be covered for a long time antibiotic for 1 month. However, if it is distal urethral stricture, I would like to abort the procedure to put suprapubic catheter for a while and urethral catheter for up to 3 days. And I would like to re-implant him later after 2 to 3 months.
Okay, so what I gather that you said it looks like a distal urethral injury because coming from the meatus, Ahmad, not from the urethra. So it looks like a distal injury. So you would abort the procedure and put a catheter and put a Foley catheter. Professor Ashur would like we say that you have the option is to continue the same and put the inflatable procedure. Now the case is for Dr. David Rarf to give us a comment on it. Professor David.
Yes, thank you. You can hear me?
Yes.
Yep. Well, I think he's got a risk factor of being diabetic. and I guess the HbA1c and the urine culture should be normal, but otherwise you shouldn't be operating on the patient. But I would abandon the case. It's only the first side. When you go back the second time, the dilatation is just as easy, particularly on the side that you haven't injured, and you haven't lost anything. If this is only 54, and remember, the best implant is the first implant, and he'll have a very nice result. But if this gets infected, that's the rest of his implant career over, because he'll have one complication after another. You'll never see the perforation. It'll always be around the meatus navicular fossa. You can't repair it. I would just abandon the procedure and put a catheter in, send him home with antibiotics, and as they said, bring him back in 3 months and do it again.
Okay, before we move this case, that's if we review literature, there is, of course, the whatever Dr. Ralph had mentioned and Dr. Amada mentioned is the classical way. There is a lot of new articles now that are supporting the position of Professor Ashur that implanting that setup, in most of cases, they will escape the risk of infection and it will go okay. However, as Professor Ralph had mentioned, that if he do have infection with the first prosthesis, then all his other prosthesis will be difficult. So we'll stop at that case. We explored the conservative approach and the more aggressive approach, but maybe because this is the first case and the patient is young and he is sexually active, that most of surgeons will lean more to abort the procedure at that time. I don't think cystoscopy is indicated. Nobody cystoscopy in that setup. And as Dr. Rafa mentioned, closure of the fistula or the injury is extremely difficult and most times is unnecessary as well.
Yeah.
Okay, we'll go second case. And the second case with us will be Dr. Saad Abu Milha, our consultant urologist from the National Guard Hospital, and Dr. Malik Merdawi, our andrologist in the military hospital. Case number 2, please. Can you can put on the screen, please? Mahmoud, can you get case number 2, please? Can you invite Dr. Abu Milha and Dr. Merdawi here on the screen, please? This is another case. Dr. Merdawi and Dr. Abu Milha, are you around?
Yes, I'm around.
Okay, can you unmute and camera, please? This is a 54-year-old male patient, as well diabetic as most of our patients in Saudi Arabia, and he had a penile prosthesis insertion almost 3 months ago that went uneventful. However, he continued to complain of tenderness over the pump, and when he come in follow-up at 3 months, he's having difficulty to do the prosthesis, and you find the swelling and induration and at the pump site, and the skin is fixed to the skin is fixed to the pump. Dr. Milha, how would you approach this case?
Yeah, thank you. Good evening, all. Sorry, I could not open my webcam. I don't know what's the problem. So let me just try. Yeah, in this patient, he has actually impending, or to be honest, at the mid of the bump area, it is almost eroded. So I have to assess the patient first if he has any signs of sepsis or local infection. And usually the most common cause of this erosion, it's infection. As long as it's a 3 months ago procedure, I would go for MRI pelvis. Accordingly, if it's only if there is no infection around the cylinders or the reservoir, I will go for excision of the bump. If I have the facility to have a bump alone, I might go for replacement of the bump only.
Dr. Merdawi?
Yes, sir.
Dr. Merdawi?
Yes.
Hello?
Yes, we can hear you.
Okay, can I continue?
Yes, please.
Yeah, so I have the option, the classical, to go for complete explantation. I might, if there is no local gross infection, I would go for Mulcahy procedure with the salvage. I will put a malleable prosthesis. The other option to remove the bump, I might convert it to semi-malleable by inflating and securing the tube and removal of the pump. I have to cover the patient with antibiotic, and I will assess him if there is no gross infection or systemic, sepsis. In case of sepsis, I have to do supplementation only without any implantation.
So what I understand, Dr. Melha, that you would do a salvage and you replace it with a semi-rigid, or you just inflate the pump and ligate the tubes. That's what you want to do.
Exactly. If there is no infection around the cylinders or reservoir, or there is no systemic, manifestation.
Okay, Dr. Merdawi, you would like to answer that? If you can put the camera, please, on yourself.
Actually, I have no idea how to put the camera, but anyway, good evening, all. Yes, I would like to counsel the patient preoperatively that we're gonna open and remove the prosthesis, the whole component, and again we will assess the area of cylinders. If there is no signs of infection, we would like to re-implant another malleable device. Otherwise, we will remove every whole component and come back again after a few months to put another prosthesis.
Okay. What about the idea of Dr. Saad that you leave the cylinders intact and you just ligate the tubes and remove the pump? You do that?
Actually, I'd like to remove everything as a classical teaching to also assist the cylinder itself and corpora itself. I wouldn't do, since there is a query signs of infection, so I'd like to remove all components.
Okay, Professor Shair, you have a comment on this? You want to comment on this?
Yeah, I actually agree with the removal of the components and performing a salvage procedure, but I wouldn't do that unless I'm almost sure it's an infection. Actually, I'm almost sure it's an infection, but it could be also erosion from manual manipulation. If there's a sticky pump syndrome, the pump is too tough. Sometimes the patient has to press hard to inflate it. So if it's not due to a hard pump, if it's not due to manual compression of the skin, and which it most probably is, then I would go for a mini salvage and replacement. I would leave the reservoir behind, no need to remove it. I would implant another reservoir on the contralateral side, or use the same reservoir, because the site of infection is quite far from where the reservoir is, but I would prefer to replace everything.
Okay, would you agree with Dr. Melha that with the idea of leaving the cylinders and just like inflating the tubes and ligating the tubing only, or you would like to remove everything if you have pump infection?
Well, with all due respect to every opinion, I wouldn't go for ligating the tubing. We don't have to. I mean, we can replace the pump if the single component is available. We could replace the whole thing, which is what I prefer. I wouldn't go for converting it to a semi-rigid because we don't need to. It's not, there's no compulsion to do this.
Okay, Dr. Ralph, you have a comment on this? Professor Ralph?
Yes. Well, there's different ways of treating this. I mean, you could just remove everything and start again. I think you have to ask the patient, does he want a malleable prosthesis, or will he eventually want his inflatable back? I mean, from a cost point of view, he's going to have 2 operations anyway. So as a safety thing, you could take, I don't think I would put anything in the scrotum when you've got a scrotum like that. So I think the choices would be to take everything out, cap off the reservoir, and do a salvage and put a malleable in. Or I have done, if there's absolutely no sign of any infection anywhere, then just remove the pump and I just connect the 2 connectors to 2 cylinder tubings together with a connector and just leave them in. And then when you come back, you take them out and do your salvage and put your 3-piece in. I don't think it makes any difference. I mean, the second option is a little bit cheaper because you're not opening a malleable prosthesis. But again, it's a little bit more risky. He's diabetic again, so, you know, that's another risk factor, isn't it?
Okay, thank you. I would agree with the people that remove the prosthesis. Is it diabetic?
So that's quite an interesting idea, connecting the two tubes together.
Yeah, what you sometimes, on one occasion, I inflated both the cylinders and just connected them together, and I left him with the malleable prosthesis. He didn't come back.
Okay. We'll go with the third case. Our debaters are Professor Saleh bin Saleh from the University of King Khalid University Hospital and Dr. Abdullah Al Khayal from the National Guard Hospital. Welcome, Dr. Saleh and Dr. Khayal. I hope that you unmute yourself and put the camera. This is kind of. This is a 51-year-old male patient who had Penile disease, and he have a of patch corporoplasty and penile prosthesis insertion almost 3 years back. He came with hematuria, and this is the picture that's on the screen, which is there. I'm not going to make it difficult. It shows the urethrogram in the picture. It's showing that there is a fistulous tract between the urethra and the corpora, and that's the region of his hematuria. We'll start with Professor Saleh for his opinion. Professor Saleh.
Good evening, everybody. Can you hear me?
Yes.
Yes.
Okay. So thank you so much for the kind invitation, Prof. Qattan, and I'm happy to be with our expert panelists and moderators. So do we have chances to ask more questions, or this is all what we got?
Yeah. Well, any question you, Dr. Saleh.
So is this guy, for instance, diabetic or not?
No, he's not diabetic. He's a post-Penile disease.
Okay. And was there any sexual trauma, for instance? When did he start having this hematuria?
He was using the prosthesis well for 3 years till he started to have difficulty inflation and the hematuria.
So that's the other question. Is the prosthesis still working or not? Can he get full rigid erections or not?
Yeah, it is. It is working, yeah.
Okay. So basically what I can see here, there is a fistula tract between the corpora cavernosa and the corpora spongiosum. And also there is a collection which looks like a subacute hematoma. Keeping all together, I have two options here. So the short answer is to send the patient to Prof. David Rath. But the long answer is to consult our reconstructive urologist. I have to sit down with the patient and consult him about the possible options here. I have to explain to him the nature of the problem and tell him that exactly we might remove the prosthesis, we might leave it in based on the intraoperative findings. So I will prepare the patient as if I am doing a new penile prosthesis. I put him on lithotomy position, insert a Foley catheter, cover him with antibiotic. Then I will do penoscrotal incision. I will evacuate the hematoma if I can. That also will be clearly showing to you, is it a urine or blood, which I believe it's blood from the lock in the T1 weighted images. Then I will separate the two corporal bodies till the area of the fistula. And then I will look at the defect in the corpora cavernosa. If it is an overly exposed prosthesis, and the guy you told me that he's not diabetic. If it's a small opening, then I will repair it with the 3O monocril, and I will repair the urethra with the 4O BDS in 2 layers. and I will keep the prosthesis. But for the sake of preventing further fistula formation, I will interpose a tissue that can be in the form of tacocell or tunica vaginalis or dartus flap. Then I will leave a Foley catheter and a suprapubic catheter for a month with antibiotic coverage. I will repeat the PCUG after 1 month, and if it's clear, it doesn't demonstrate any leakage, then by that time we can remove the Foley catheter and start activating the pump. That's what,
so what I understand,
think to the best of the patient.
What I understand that you're going to explore the area of the fistula, you are going to repair the urethra and the corpora, and you're going to keep the prosthesis and divert the urine. That's what you're going to do. Okay?
Well, provided that the exposure is minimal and the prosthesis is functioning.
Okay. We'll listen to Dr. Khayal, Abdullah Khayal. Dr. Abdullah, are you around?
Yes, thank you, Prof. Saeed, and thank you for all the organization and moderation of this session. I agree with Dr. Saleh in some point. However, probably the incision that I will do is not penoscrotal. I will go through a perineal incision because of the area of his fistula is very proximal. It's at the bulbomembranous junction. It will be very difficult to access it well through a penoscrotal incision. And if I find that the fistula is actually large, I will probably do a formal urethroplasty and a stomatic end-to-end rather than just closing it, because I'll be worried about forming a stricture in the future and narrowing the urethral lumen at this point. Regarding the prosthesis itself, if the opening at the corpora cavernosa is large and there is a purulent discharge and this collection is actually an infection, I will remove the prosthesis, close the corpora cavernosa. I will not re-implant him at that time with 2 anastomosis. If the fistula tract is small and I'm not worried about the urethral lumen, I'll probably just close the urethra, and if the prosthesis need to be replaced, then I will replace it. I agree with Prof. Saleh that he will need a tissue interposition with either tunica vaginalis or tacocell. But I will, again, I will not go through a penoscrotal incision. I will go through a perineal incision instead.
So Abdul Kawat, understand that you are going to go directly on the fistula. You find that this fistula is too difficult to close from the suprapubic, from the penoscrotal. You go perineally, and you are going not to close the fistula, but do a formal urethroplasty and most likely remove the prosthesis. That's what I understand.
Yes.
Okay. Professor Ralph, you want to comment on these 2 approaches?
Yeah, I mean, I think you'd find it difficult to get to the fistula from a penoscrotal incision. I think you need to do legs need to be up in the lithotomy position and do a perineal incision, because, as you said, you might end up doing a bulboprostatic anastomosis, and with all of these things, the urethra takes preference over the implant, I'm afraid. And I've never seen this. I've never seen this complication with a urethral pathology so high up. I mean, this is up near his prostate. This is, and it looks quite a big fistula from the X-ray, from the urethrogram. It doesn't. I mean, it's quite a big collection, isn't it, going into his urethra? So, and no one put catheters or anything. He just came like this. There's no other pathology.
It might be catheterized in the past. This is what we have when the patient came. It might be catheterized sometime in the past, or it can be an infection that had eroded. We don't know.
Well, I would just say, because this looks to me more like a sort of a traumatic catheterization, you know, at the level of the prostate when you're trying to get a cath. But I think you're going to lose the cylinders of the implant here, I think. I mean, you've got to do the urethroplasty first and then come back and do the implant again.
Okay, can I have a comment? If I want to go very conservatively, if I just put without repairing the urethra, if I just put a Foley catheter and kept it for a while and remove the prosthesis, doesn't have a chance that this fistula can close spontaneously if you remove the foreign body and put a urethral catheter alone? Can that work?
Yeah, I mean, I think it would be quite nice to see which side, because it would be nice to leave one cylinder if possible, because there shouldn't be communication between the left and the right at 3 years because it's got its own capsule. So if you could find out which cylinder it is and just take one cylinder out, and I think if it's been there a long time, it's probably not going to close though. If it's sort of,
okay.
you know,
The consensus now that you are going to approach that through a perineal incision, and with whether you either close the fistula or do a formal uretroplasty. It's difficult, of course. It's very, it's very specific.
You have to make a decision when you see where the fistula is. It really.
Okay, we'll move to case number 4, and we have our panelists will be Dr. Mohammed Abbous, our eminent andrologist from Ilaj, and Dr. Abdulaziz Baazim, our andrologist from Jeddah. Welcome back. Are you on, Dr. Abbous and Dr. Baazim?
Yes, can you hear me?
Yes.
Okay.
I'm on as well.
Okay, this case number 4 is a 60-year-old male patient, diabetic. He had penile prosthesis insertion, almost 1 year, and then he came with that picture. The tubing had eroded through the skin 1 year. Patient is asymptomatic. The procedure is functioning, and he still can perform intercourse. We'll start with Dr. Baazim.
Okay, thank you. Basically, erosion of the tubing alone is not something that we see commonly. And I think we can all agree that this patient will not get better. If we, yeah, can you hear me?
Yes.
Yeah. Okay, so what we would hope for if we don't do anything is that he stays the same. I don't think that we can hope for him magically covering up this tubing on his own. So that's why I would favor intervention, because best case scenario, he stays the same. If we don't do anything, worst case scenario, this becomes infected and we need more drastic measures. This patient, although he's diabetic, he is relatively young and he is healthy enough to have regular intercourse. So we expect him to live long enough to give a chance for this to become infected. So then we entertain which surgical option do we perform on this patient. We can consider replacing the device, replacing everything. That's something that you would consider with an erosion. However, there's no evidence of infection here. Basically, no purulent discharge, no erythema, and the device is relatively new. It's a year. If it was, say, more than 5 years, I would consider changing everything. In this case, what I would probably do is just excise the eroded skin and create a new pouch for both the tubing and the pump, and close the skin over it.
So what I understand that you leave the prosthesis, you are just remove the skin and keep it in and put it inside and close the skin cover on top of it.
Yeah. Yes, I would swab the tubing before surgery and wait for results just to know if these are if it grows normal skin commensals or any particular pathogens. And yes, I'd make sure that there's layers over the tubing to make sure that try to prevent this from happening again.
Okay. Dr. Abbous, you have a comment on this? You want to tell your approach?
Assalamu alaikum. Good evening, everybody. Thank you, Professor Gatan, for this kind invitation. It's my honor to be among these eminent experts. For me, depending on my experience, I would not touch this patient until I had to. Means that I will just check him first locally, if any tenderness, any pain, any redness, I mean any signs of local infection. I will also check if the leukocytic count is normal, and as long as no signs of local infection or systemic infection, and also the device is functioning well, I will not touch him. I will just be careful with him to inform him if any of these signs or symptoms would suggest infection to contact me at once. Otherwise, I will leave him functioning as long as the device is functioning and he's symptomatic. Because there is no guidelines for such cases, this depends on the experience. I had such cases before, and I encountered a bad prognosis when I tried to interfere go surgery. So I will not interfere or go surgery until I have to. And this time, I may expect that he might go for another year or 2 years or 3 years. This will save him a lot of trouble enjoying his device and having normal sexual intercourse.
Okay, so it's clear now. Will Usama, Dr. Bazim want to operate and hide it, and you said you will sit down till you complain. Professor Usama, what you're going to do with this patient in your clinic?
Well, as Dr. Habous said, there are no guidelines, but the general rule is if a part of the device is showing up, you should remove, wait, and replace. Recently, I've heard some eminent influencers in our field say that you can just push it back inside. I'm skeptical towards that. But I would give it a shot. I mean, what do we have to lose? If you open up on these tube, apparently this tube eroded because it was too long. I think this is the tube going to the reservoir, and apparently it was too long and kinking. It caused some pressure atrophy, just like a stitch sinus. So I would shorten the tubing, wash out, reconnect, and close in layers. It's a minor procedure. It will not do any damage. And if there was damage that was meant to be due to this case, I would like it to happen so that I can remove. So I would give him his best chance by shortening the tubing, reconnecting, washing out, and closing in layers. I would like to hear what David has to say about
that. Well, maybe I'm a slightly old-fashioned, but it's the number of operations that the patient's going to have. I mean, I think the implant looks fantastic. I mean, the safest thing is to take everything out and put a new one in. And the reservoir should go on the opposite side. I mean, that's the safest thing to do, and that's one operation. I guess, I mean, I have had a patient that's got away with it by putting it back under the skin. He's diabetic. He's got all these risk factors. I mean, you could try that. You haven't got anything to lose. But what you really do have to keep a close eye on the patient, because if there's any worsening of the condition, I mean, it may prevent you from doing a salvage rescue procedure. So you've got to keep a very close eye on the patient.
David, would you consider a salvage in a diabetic?
Again, that's a contraindication. I think if it's a well-controlled diabetic and it's a situation like this, where clearly there's no real infection within the shaft, I think I'd probably go with this. You know, if it's obviously red, swollen with pus, then obviously not. But this is quite as you said, this is probably the reservoir tubing too long. And you definitely need to shorten it. I guess that the tubing may be infected, so you need to pull as much out as possible and try and remove the tubing that's visible there.
Prof. Katan, are you there? I don't see you. Prof. Katan?
Maybe we should go for the next case now.
You yes. Can go both now for the next case, as both Katan take 2 minutes. You can go for them.
Okay, so let's move to case number 5. And here, actually, I'm debating this with Dr. Maher Muaddin. Dr. Maher, are you there?
Dr. Maher didn't enter yet. You can begin, Dr. Naif, with the answer.
So this is a 43 years old male diabetic. He's post-mandible penile prosthesis 6 months ago. Presented with a penile swelling, pus, urethral discharge, and he was receiving oral antibiotic empirically. Then he developed proximal and distal fistulas. And both those fistulas, you can see the orange arrow there, that was draining pus and urine. And there's another one at the corona on the right side. So there are two areas that draining pus and urine and everything. So I don't know what is Maher. Maher is not there yet, Mahmoud?
Yes, both Naif. You can discuss it with both Osama and both David.
So actually, the reason we brought this, he's a true patient. He's my patient, actually. So, you know, he's a 43 years old. And unfortunately, when he was implanted 6 months ago, he had the infection 2 weeks after the surgery. But, you know, he was advised, because his implanter was in another country, so he was advised to open it every now and then and drain the pus. So, and then he ended the bypass. So he was sitting in my clinic in severe pain and looking septic, and this is the picture. As you can see, there's a wet gangrene, and there are fistulas of so urethroperitoneous fistula. One down there, the small one. One is the biggest one is up at the corona. So he was, you know, initially he was booked immediately for explantation. If you score him, you will see both prostheses in the urethra. So you know, his no. Can you go back? Yeah. So then he, at this stage, actually, he had an immediate explantation of the prosthesis, a suprapubic catheter, and aggressive debridement. Now, the question is that here, would yes, everybody would cover him with antibiotic, antifungal maybe, because he had yeast, and divert the urine. But would anybody go at this stage for penile amputation? Anybody would do that? Let's start with Dr. Saeed.
I don't. Does that mean no? I wouldn't amputate a penis. No. I mean, because you're going to get a. You take all the prosthetics out, drain the urine, and then treat the urethral strictures first, and then try and put another implant in second. Get a vacuum device going as well. Otherwise, he's going to have a really shrunken penis.
Yes. So so what he had is that he had a debridement, but then, you know, we had to do 3-4 debridement 2 weeks apart, each one, or 1 week apart, because this guy was still draining, despite the fact that we removed the prosthesis. Still the gangrene was wet, and still he's, you know, sloughing necrotic tissue here and there. And so, despite, can you move the picture? Can you show me, Mahmoud, the other pictures, please, of this case? So I'll just show you after debridement and after a culture-based treatment, what happened later on. Yeah, if you can, yeah, show us those pictures. So as you can see, look, the gangrene has regressed just to the glands. Can you move more? More picture, please. More. Yeah. Now this is closer. Wait here. So as you can see here, this is the urethral blade. As you can see, this is what he's left with, gangrenous glands. This is not all of the glands. This is maybe half of the glands gangrenous, and this big fistula on the urethra. So you know, he's a 43 years old. His diabetes, you know, is controlled now, and you know, he wants future intercourse and a young wife. So at this stage, how would you take it next, Prof. Rao, from here?
Well, God, this is a complete and utter disaster. I mean, it just shows that when you have an infected implant in a diabetic, take it out and don't. I mean, this is 3 months down the line. You can't treat infections in diabetics, in diabetic implants conservatively. But now, obviously, he's lost his. I mean, it looks to me like he's lost his whole glands there. That's a bit of corporal tissue. I guess you just got to debride all the dead stuff and just wait and see what you're left with. That I don't think he's going to be very happy with the end result. And he could end up having a phalloplasty of some description.
Yes. So, Prof. Shuair, what do you think? So what we see here is the catheter. Huh? This is the urethral catheter going from the meatus and going down. There's this big fistula here. He's left with this much of gangrene to the glands. Dr. Shuair?
Yeah, I would have done what you have done, which is urgent removal of the implants, antibiotics as per culture and sensitivity. And I would consider a flap. Maybe I would bury the penis in the scrotal, in the dartos muscle within the scrotum to gain extra vascularity and try to reconstruct with the scrotal skin, maybe. It's the closest that can be to the penis, which is, I recall it's called Sicil Culp procedure. David? Is it the Sicil Culp?
Culp, yeah.
Yeah,
I think you're gonna have to remove that dead tissue first, though, aren't you?
Of course, yeah, sure. So I said, like, we remove the implants, we debride the dead tissue, and when the infection is resolved, you do a Sicil Culp to reconstruct the penis accordingly. And then when you re-implant, if there's ever a chance for another implant, I would consider shortening the implant, because if you go back to the first two pictures in the PowerPoint, the one on the right side was showing an S-shaped deformity. So probably an oversizing was the reason behind what happened.
Yes, that's a good point. So
if you could bring back the pictures of the PowerPoint.
Naif, you want to continue?
Yeah. Can you move? Excuse me, Prof. Shuair. I just want to show you the end result. What I did here. Actually, the option was urethrostomy, and because he's bothered with a catheter now. He has a urethral catheter. He has a suprapubic. So would you? I remember even at one point, Prof. Chappelle was doing a professorship at King Faisal. So I showed him before this picture. Then I showed him this picture. He said, just go for penile urethrostomy and forget about this. So what they did is that, that fistula is beyond repair, and he's left with all that necrotic tissue. So I did as Prof. Ralph said, and Prof. Shuair also. So I removed all this dead tissue, and then I did the myetoplasty, urethroplasty. So can you show us the end result, please? Yes. So this is the.
That's quite a nice result there, Naif.
Very nice. This is
nice.
the guy. This is the guy I sent you the picture, Prof. Ralph. When I told you Dr. Chappelle was here, what do you think? He's refusing totally to be like a woman and sit in the toilet and feel like a woman. No, he wants his urethra back. So this is the end result. So the message from this is that don't lose, the game with those guys. See how much we started with, and now this is what we are left with. So he regressed. Yeast was treated, Pseudomonas was treated, Klebsiella, anaerobes. He was diverted completely, and this is the end result. Now he can be at least like, and the fistula down there at the penoscrotal area healed completely with the.
What exactly did you do to end up with this excellent result? Congratulations, it's marvelous. What exactly was your approach?
Yeah, so after treating the infection and doing, as I remember, 3 to 4 debridements, and then we're left with the picture that I showed you, the last one. So that was so I removed all the necrotic tissue, and then the glands. Okay, what else were left with the glands like that, and the urethra was here after I chipped it with the. So what I did is that I have ingenited the glands to the urethra, so it's like a myetoplasty. You get my point? So all those wings of the glands, I sutured 6 to 12 o'clock from here, 6 to 12 o'clock from here, and this is the end result.
Congratulations, it's a marvelous result.
Thank you,
I think it's a very good case. I think the message from that, remove the penile prosthesis and be conservative with the excision of the necrotic. Don't end the patient with a short penis. The penis heal. Don't be aggressive in your initial resection. Don't amputate. Just debride, and then eventually you might have a result like this. I think it's a very good case. We'll go with the case after this. Case number 6, please. And we have Dr. Muhannad Al-Harbi, and we have from the same area, and Dr. Amjad Al-Wal, Saudi Arabia, practicing in the United States. This is a 70-year-old male patient. he have ED, he is hypertensive, non-diabetic, he have inflated penile prosthesis 1 year back, and he come to the clinic with pain during intercourse, and he can feel the tip of the left cylinder just bulging below the meatus. We can feel it, we can see it there. So we'll start with Dr. Mohamed Al-Harbi is on the screen now. If you tell us how you're going to approach this patient. The prosthesis is still functioning, and but he having the pain with intercourse. Mohamed, تفضل.
Thank you for the invitation, and hello to everybody. So for this patient, since he doesn't have any signs of infection, I don't see any redness or any induration, and I don't see any pus discharge. I will do a distal Mulcahy corporoplasty. So I will open a distal incision. I will open over the cylinder. Then I will assess the tunical defect near the urethra because it's impinging on the fossa ventricularis. So I will do a purse string for that to strengthen it. Then I will deflate the cylinder, of course. Then I will open the back wall of the fibrous capsule and reroute the cylinder. So maybe I will use a guide string because I'm going to use the same cylinder, and I will fire the furlough, making sure I go a bit more lateral. And of course, I will do mini washout for him. Yeah.
Okay, Dr. Amjad, so you are going to explore through a distal incision, subcoronal incision. You mean subcoronal incision? What distal? What incision? A subcoronal incision, and you are going to reposition and do a corporoplasty. Are you going to use? Let's see what Amjad will do. Dr. Amjad, how are you? Please.
Yeah, good. How are you, everyone? So for me, I would do almost the same thing. I would have started with a penile incision, get the cylinder out, pass a dilator, and try. Obviously, this is not an eroded yet, but it's an impinging erosion with an extrusion. Pass the dilator, and then try to do corporoplasty by another incision. Over the area where it is extruded, and then I'll try to do depending on the way it looks. If it looks like the distal corpora is okay, I could just end it right there by doing corporoplasty and fixing the cylinder over that. If just like what Mohamed did. Now, if it shows me that the distal corpus is quite weak and damaged, I don't know if this is the first penile prosthesis or not. But if it's a very damaged corpus, I mean, the windsock graft would be an option here to try to strengthen that area. So this problem won't happen again. But it's not necessarily in all cases.
So you mean that you Gore-Tex graft? You mean Gore-Tex graft, Amjad? You put a graft?
The Gore-Tex graft, if it looks really weak distally. But if it looks okay and it just extruded and I could do a simple corporoplasty, I mean, I'll get away with that. If there is a weak corpora distally, I will consider grafting at that point in addition to the corporoplasty.
So the difference between Dr. Mohamed will go only subcoronal and try to fix it from there. You are going through 2 incisions because you need 2 incisions, and you might put a Gore-Tex graft if you think it's necessary. Professor Osama, you want to comment on this?
Yeah, well, we all three of us agree on rerouting the distal Mulcahy procedure, and Dr. Amjad suggested a penoscrotal approach as well. But my concern is what caused the impending perforation in the first place, and how would we avoid it happening again after these wonderful procedures? In my opinion, it should be dated. I mean, when did you start having the tips of the cylinders under the glands right close to the meatus? If it's been like this since the procedure 3 years ago, and you only suffered today, then we need to remove an extender, a rear tip extender. We need to shorten the implant, maybe replace it altogether, because if you keep the same components, you have a 10% risk of infection, and you need a mini salvage. If it's not, it could be some fibrosis that has set in, some Peyronie's disease that has developed and caused shortening. In this case, I would suggest scrapping off the Peyronie's disease or the intracorporal scrapping of the Peyronie's plaques which Purito has spoken about recently, and I have also published the punch technique where you remove the fibrous tissue plate from within with the punch forceps. If it's post-traumatic, then it's post-traumatic. You need to do nothing. Just warn him not to be careful with the lady on top position. So basically, I want to know how it happened, why it happened, in order to avoid it, and to assess if I need to shorten the cylinders.
Okay. Professor Ralph, you want to comment on this as well?
Yeah, I think the implant's too. I think the implant's too long, and so you'll need 2 incisions. You need a penoscrotal incision to shorten or remove the rear tip extender or change the implant. So I think you need a second incision, and it's difficult to. I mean, because you've got the thumb pressing on there. I don't know how much room there is in the end there, or whether the whole cylinder has gone right through the tip, in which case there'll be a pretty big hole there, and it will be quite difficult to do a Mulcahy if that was the case. I mean, if there is tissue on the side, then that's great, then I would do that as well. But remember, we can use mesh graft as well, but you need to try and keep the mesh away from the urethra, because then you could get erosion.
Okay, so the consensus here that the cylinder might be long, and it is left like this. It might tend to repush itself again the same weak area and come through the urethra. So it might be useful to remove rear tip extenders to decrease the pressure on the corporoplasty side. In King Faisal, we used really mesh on several patients, and in fact we are publishing a series of using a vicryl, a non-absorbent mesh in that area, which worked fine. But I totally agree that leaving it long cylinders, even if you do corporoplasty, it might push through whatever corporoplasty you're going to do. So better is to approach by 2 ways: a way to decrease the size and maybe and fix it there according to situation, whether you put a mesh or just do a corporoplasty.
Yeah.
Well, thank you very much, our debaters. And case number 7 will be presented by Dr. Naif. Dr. Naif, you want to start?
Yes, please. So I would like to call Dr. Talan Merdad and Dr. Raad Al-Mania. Both are there. I can see Dr. Talal. Dr. Raad, are you there? Yes. So welcome to our debate today. A 42-year-old male who's diabetic underwent multiple revision surgeries for penile prosthesis before. He was undergoing revision penile prosthesis due to the device malfunction through penoscrotal incision. Upon the tissues proximally to reach the tubing, unintentional 1 centimeter urethral injury was not. So what would you do at this stage? Let's start with Dr. Talal.
Thank you, Professor Saeed, Professor Naif. It's been a pleasure and honor to be with you in this excellent webinar. This is not a straightforward answer case because it depends on the clinical judgment on the spot during surgery. He's an unfortunate patient with multiple revisions. And I wonder how come he have this injury to the urethra and Foley catheter is inserted during the procedure, or there was no Foley catheter. Anyhow, the way I will go for this patient is to primarily repair the urethra and remove the malfunctioning prosthesis and insert a new one after thorough antibiotic irrigation. In the same time, I will keep a suprapubic catheter for at least 10 days to 2 weeks, just to avoid any extravasation of urine from this urethral injury. As I said, this is depend on the clinical judgment during surgery. It's not something we can consult the patient or ask the patient what to do. He's already under anesthesia. Thank you.
This noise coming from? Yeah, Dr. Raad.
Okay, so this case, there are 2 options. Me, I would prefer to actually abort the procedure, because if you understand our medico-legal system will be indicted. So in this patient, if the tubes are exposed, I will remove everything and repair in 2 layers and drain the patient. If the tubes are not exposed, we did the injury at the beginning of the procedure, I'll just do the 2-layer closure and drain the patient. If we attempt to change, we will go into the dilemma of keeping the Foley catheter, and if the fistula happens, increase the friction with the penile prosthesis, increase the risk of infection. Although there is multiple reports that it will be successful, like Dr. Saeed Gattan last abstract in the SUA, like Burnett report also, but it is still didn't change the standard of care. And if this case goes to the court, most probably you'll be indicted in case of infection if you repair. So my opinion is to abort.
So thank you. You can see the part of the andrology and the reconstruction. Huh? So Dr. Raed is blessed with the being reconstructive, so he's overcautious. So we have 2 schools, Prof. Shuair. Dr. Talam Merdad would continue, would repair it and continue putting the prosthesis. I wanted them to answer whether he will proceed with a malleable versus because the malleable is continuous stretching of the urethra versus the inflatable where you can deflate it and leave the urethra to heal. But Dr. Raj, fourth and plus minus remove the prosthesis if it is exposed. What do you think, Prof. Shuair?
Well, the implant was deemed to be removed in any case. It's malfunctioning. But from my understanding that the surgeon was searching for the tubing, so he hasn't yet performed the corporotomies. So the implant is well kept inside. The malfunctioning implant is well kept inside. And it's a clean procedure. I mean, it's a clean-cut surgical injury. So I would go for reconstruction, interposition, and I keep the implant as for space preservation. And I come in later on, or of course, diversion, and I come in later on with the new implant. We've been trying to publish the utility of chlorhexidine gel urethral irrigation before the implant. And I think if we adopt this universally, if such an unfortunate incident would happen, you would comfortably repair the urethra and proceed with your implant. But for the time being, this is my answer. Keep the implant, repair the urethra, perform interposition, coming back later to replace it. David.
Well, the teaching in a virgin case is that you can just repair the urethral injury and then continue. I mean, clearly the risk is higher here because it's revision surgery and diabetic patient. I guess it can go either way here. I don't think you're at too much risk. Well, he's a diabetic. I think I'll probably be conservative like yourself, Osama. Because of the diabetes and revision, you've got more than one risk factor here. So probably you need to keep the tubes away from your urethral repair. So either you can either cut them down short and leave the implant in there, but you don't want the tubing anywhere near your urethral repair, which you'll do in 2 or 3 layers.
Okay. So that's very important.
I can add one 10 seconds. I think the point here where you put this case that people abort the procedure afraid of medical legal consequence, as Dr. Munir had mentioned, because of risk of infection. I think that's the main reason. However, the studies that show, bacteriological studies that show that the urethra is colonized mainly in the fossa navicularis, and the more proximally you go, you find less and less urethra. And in fact, where you injure the urethra at the penoscrotal junction, the urethral colonization is minimal. So the risk of true infection at that site is very minimal. I would go with Dr. Talal that I would say that for this very proximal injury, I would close in 2 layers and proceed with my surgery. I would not do that with the distal injury at the fossa navicularis, but I would do it definitely with a proximal injury. I think just I'd kneel to Talal's side. I know that's conservative. Okay, sorry for interruption. Please, nice.
Sure. So we can debate this. Like in the conclusion here, we have 2 schools, and you either close the defect 2 layers, and then proceed with the prosthesis. Versus it depends on many factors. No, but just to remind you about the Sexton survey, you know, when he did it at the AUA, he distributed a survey to more than 100 enterologists, actually, fellowship-trained urologists, and you know, their answer was they encountered one or twice urethral injury in their career life, and most of them opted for closing it and proceeding. So I don't know about the medical legal, unless I don't have a proof for that this will increase my infection. I don't have an proof that I can count on. But yes, it's, you know, both views are there. Actually, can we move to the next case, please, before time? So I would like to call number 8. I would like to call Dr. Adel Al-Dail, Dr. Abdul Karim Gibran. Dr. Adel Al-Dail is our senior urologist and neurologist from Eastern Province, and Dr. Abdul Karim Gibran from the South. Are you there, both of you, Dr. Adel and Dr. Abdul Karim?
Yeah.
So,
you hear me? Thank you.
Yes. Dr. Abdul Karim, are you there?
Hello.
Dr. Abdul Karim Gibran. Okay. If he's not there, I'm going to read the history.
It's okay.
This is a 60 years old male, diabetic with erectile dysfunction. He is post-malleable penile prosthesis 2 months ago. He presented to the clinic with a painless dry gangrene, no discharge, and the guy is really happy with this. He's doing an intercourse with this black stick. So, Dr. Adel, what do you think?
Okay, thank you, Dr. Naif. I think such a case where he's presented very early post the prosthesis, definitely this is dry gangrene due to tension tapping the vessels and due to necrosis at the glands. Now I can see also some edema around it and some oozing just below it. It is taking 1/3 of the glands. It's very difficult to convince such a guy that you're going to remove the prosthesis, because he's functioning sexually. He'll be trying to hold on the prosthesis. Primarily, I'm going to treat him conservatively. Start with antibiotic. I don't see the meatus, so possibly I may need also to put suprapubic catheter that it may close during the procedure. That happened with me. I've seen a few of these cases, and happened that the meatus closed during the procedure, during the follow-up period. Classically, the best thing is to remove the prosthesis, so you give him enough chance that he will have better perfusion to the glands. But if he insists that he's going to keep it, at least the conservative management will elevate the edema and will limit the gangrene. In the cases I have seen, the depth usually about 1 to 2 millimeter. And sometimes in certain areas, it get deeper than that. So if it get deeper to the prosthesis, then that side has to be removed in any case when you go to the debridement. Mostly you are not going to win without removing the prosthesis, but you can try it as far as he's functioning sexually, and most probably he would like to hold on the prosthesis.
Okay, so Dr. Karim Gibran, I saw that your joint is there.
Hello, do you hear me?
Yeah.
Hello?
Yes, go ahead. Yes,
I would like to thank all organized committee and all speakers, and special hi to Professor David Ralph. I trained under his supervision. For me, this case is three factors. The patient is old and he's diabetics, and he's malleable prosthesis, and from this gangrene, I will be very safe and remove this prosthesis and salvage, and I wait for him to be totally cured. Then I will bring him back after a couple of months for another prosthesis.
So my question is that, do you think this is for our actual speaker, Prof. Shuair and Prof. Rab, do you think this is a reversible thing after 2 months? So because see, if we don't think this is reversible, that this dry gangrene will slough off, that why should we remove the prosthesis? So what do you think, Prof. Shuair?
I would remove it straight away. This could be your case, Dr. Naif, but an early picture. So I would,
Yeah.
I would remove
Well,
it
Lee
straight away.
has the experience now.
But if upon replantation, yeah.
Guys,
say again.
I don't want to market myself as a gangrene guy, please.
No, it wasn't your case in the first place. So,
Yeah.
sorry for that. So, but when I have him back after a couple of months, if I'm gonna reimplant, I would go for an inflatable.
Okay.
Because this guy is semi-rigid to an inflatable, and what I would use to preserve the space would be, if available, maybe the carrion cast or the mitomycin.
Yeah. I think the general rule is that if you see an ischemic glands or necrotic glands, you take the implant out. That's the first thing you do, because this, if you left it in, it's going to progress to, well, it'll erode out through the end because it looks a bit infected as well. Actually, not just right, you know, the below it where your finger is looks a little bit swollen and infected. So he'll end up with a urethral complication, and his penis will be destroyed again. So whenever you see this in a diabetic patient, just take the implant out, get him on a vacuum device, and then put it back in at another time.
Would it make a difference, because we can see that there's gangrene more on the right side? Would it make a difference if we remove that side and leave the other side?
I don't know the answer to that, but I think the safety thing is, well, you could shorten one, but I think you'll probably find it's infected in there.
Yes. So seems that we have a consensus here of removing the device, come again after 2-3 months.
Yeah.
Okay. So can we move to case number 9, please? So can I call Dr. Abdullah Al-Fakhri and Dr. Ayman Al-Bakri, please?
Yes.
Are you there, Abdullah Al-Fakhri?
Hello. Yes.
Yes. So case
Can you hear
number
me?
9. Yes, we can. So a 52-year-old male with erectile dysfunction, he is post-malleable penile prosthesis insertion, presented to the clinic after 1 year of this picture, and he has no pain, no discharge, he's doing intercourse despite he has this golf ball there. So, so what would you do, Dr. Abdullah Al-Fakhri, in this case?
So, first of all, I'd like to thank you all for this invite and a great webinar. Regarding this patient, I see in the picture there's some kind of a discharge coming from the last picture. It seems to be like a bus. Anyway, it's like infected, and there's exposure, of course, of the prosthesis. So I would go for sure removing this prosthesis. I will also remove the contralateral side because it looks actually a very bad infection, although he doesn't have pain. I would like to debride it, do irrigation with antibiotic, give him antibiotic treatment, and maybe for the contralateral side, I would put a spacer and leave him for 3 months. Then again, I will come back after he is completely healed to insert prosthesis, again, a malleable one. But I would at least give him a time to this infection to resolve and the skin to go back to its normal. I know it will be difficult, but I think it's very difficult to do salvage in this case.
Okay, so you would remove both prosthesis, wait, and come again another day.
Correct.
Dr. Ayman Al-Bakri? Dr. Ayman, are you there? I thought he's here. So it's not. Let's take this thing. I think this is Prof. Kattan's case. So we'll take it at the end. So Prof. Shair, so somebody who's coming with this picture, prosthesis is functioning, let's say, and it's shown from the from this. Of course, you swab him, you give antibiotic, but would you remove one side? Would you remove both sides? Would you, would you replace it with another one and batch it? What would you do?
Well, these are very curious cases. I've seen a couple of those, maybe 2 or 3, and I wish I had a way to follow them up and see how they ended up. They were not mine, actually. I would remove this side. I mean, the patient doesn't want to. like I tell him he has to remove it, the patient just disappears. That's why I cannot follow him up. I don't know where he ended, how he ended up. Anyways, if the patient would abide by my advice, I would remove this side because the other side has probably a capsule around it, and the guy's functioning fine, and it's semi-rigid. So I would remove this left side, I assume, and I would do an extra capsular implantation. I do not implant in the same place. I open the back wall of the capsule and I implant behind it.
Okay.
Yeah, I mean, I think I'd do the same. I mean, I would take the implant out. I'd make my well, I would do all my operations at the site of where the erosion is. So in other words, remove the implant at that site. I would probably just look inside and just make sure that I can't feel the other prosthesis or see the other prosthesis rather, because then you probably have to take both out. But hopefully just the one cylinder comes out. I would then clean up all the edges and swing up a scrotal flap to cover the wound, because you've got to get this closed, and then come back another day and put an implant in.
Okay, this is a knife. In fact, I just have one. This in fact is my case. It was almost a year ago, and we followed what Dr. Shair and Dr. Ralph. The removal was we removed only the one side through an incision at the same side. We closed the corpora, and then we mobilized the skin. We did not need a scrotal flap. The skin closed nicely, and in fact, the patient was asked to continue on intercourse with one cylinder. He was not satisfied, and he came after 6 months and requested, and we managed to put another short semi-rigid prosthesis on the other side. It was not so difficult, the replacement after 6 months, and he's now functioning with 2 prostheses. We tried to convince him to continue with 1 cylinder only. He was not satisfied, and he requested, and that's what done. We kept the other. We did not remove both prostheses, both cylinders.
Question, Dr. Kaplan. Where did you implant the replacement cylinder? In the same cavity, or did you implant it extra capsular?
I didn't find the capsule when we went the next time, but there's no capsule. It was just fibrosis. It was fibrosed corpora. I did not identify any capsule. We did it the routine when we deal with the fibrotic corpora. We tried to tend it to put a shorter type of prosthesis and than the other side, but it's functionally and cosmetically was well. We did not identify the capsule when they came after 6 months. It was just totally fibrotic.
Yeah.
And the other side was well kept without problem.
We did not touch it. The whole thing that when the new cylinder we put was at least 1 centimeter shorter than the other one. That's what we're not able to dilate more than this. But he was functionally satisfied at the end of the procedure.
Great. Thank you. For the time sake, we have to move. Dr. Ayman Bakri is texting me actually, and he's saying his opinion is to remove both and come again another day. So case number 10, please. Dr. Khalid Al-Rabi'a, our consultant andrologist, urologist from National Guard, and Dr. Abdul Majid Beiti, our consultant urologist andrologist from Military Hospital. Both of you are there?
Yeah, I'm here.
Okay.
Yes,
so 54 years old. Okay, so 54 years old male, Mali, to your clinic complaining of deep pelvic pain, your intercourse with poor axial rigidity, poor erection for 6 months. So let's start with Dr. Khalid Al-Rabi'a. What do you think?
First of all, I would like to thank Prof. Kattan for the invitation. So I just have a couple of questions. Now, on exam, were you able to feel the prosthesis?
You mean perineal, right?
Huh?
Yeah, this is a case of proximal perforation.
No, I know. But on exam, were you able to feel the prosthesis?
Yeah, if you put your finger there deep, you would feel, yes. But it's
no,
not
distally.
Distally down. It's down, so it's not at the tip.
Okay, so in the penis there is no prosthesis itself distally?
There is one side, but this side which has perforated, it's down.
It's down, huh?
Yes, mid-cap.
So one prosthesis is down. So
yes.
so basically, I mean, never seen a proximal erosion in 6 years. It's not that common that I've seen that. But anyways, what I'm gonna do is the following. I'm gonna remove that side for sure. And you know, if the guy is healthy, it doesn't seem that he's diabetic, I would try and redilate that area. I would go with penoscrotal approach, remove it. Okay, so, since you can feel the distal part of it, I would remove it completely. If I get it all, that's great. If I get all the parts, and then I would redilate to the proper track, and then most likely I'm going to put you know, a wrap, a Dacron wrap around the proximal parts. I might also put a stitch on the cylinder as well, and attach, hook it to the nearby also corpus cavernosum. If the wound is clean and everything, I would just replace it just the same procedure. Yeah. So
okay.
that's what I would do.
So go with it again, trying to fix the process there and proceeding with the case. Dr. Abdelmajid Fethi.
Yes, thank you for invitation and hello, good evening, everyone. You heard me?
Yeah.
Yes. Yeah.
Yes, we can.
Okay, sorry. What I see in this sagittal MRI view is migration of the left malleable cylinder proximally through the perineum, reaching to the anterior rectal wall. But fortunately, it's not perforating the rectal wall. Actually, there is no mature guidelines for managing this condition due to the rarity of this condition. But if he's my patient, I will approach this migrated cylinder by incision at the penoscrotal area with dissection until I reach to the affected corpora that need to be opened and extract the migrated cylinder. And then the next step to create a channel for the cylinder distally by dilating the distal corpora. Then the cylinder can be reinserted at this time with fixing it by a stitch at the corporotomy closure site to prevent the recurrence of the migration. Alternatively, if the proximal corpora is deficient or unhealthy to accommodate the instruments, dilators, and subsequently the cylinder, we can create a mesh in a windsock manner to be reinforced to the tunica albuginea.
Okay, so in summary, both approaches would be going penoscrotal, redilating distal, and trying to fix the prosthesis. But maybe I missed you guys. Did you say inflatable or going with a malleable? I thought it's malleable.
With malleable, I would proceed with malleable with the same cylinder.
Okay. Same here. I'm gonna just do one side.
Okay. So, Prof. Shair, what do you think?
I believe it's Professor David's case.
Yeah, I take both.
Anyways, this is a malleable. If it was an inflatable, I would have wanted to open penoscrotal in order to be able to fire the furlough and reposition the cylinders distally after I'm done with what I'm gonna do proximally. What I'm gonna do proximally, I'm gonna save right now. But since it's malleable, then I do not need to fire the furlough, so I can approach it from the penoscrotal incision or the perineal incision, whichever way I want it. Now, if this is a fresh posterior perforation, it could heal after I reposition the implant and maybe perform a windsock or make a mesh. But since it's an old perforation, it's been there for about 6 months, then it's least likely to heal. I would want to repair it directly. So I would open a perineal incision right on the implant, on the ischial tuberosity, and I would identify the site of the tear and repair it primarily, maybe put a mesh, and I push the implant in. Of course, the downside of this is that this is a more infected area, so this is the pro side of the penoscrotal incision. So in short, 6-month injury, malleable, I would open perineal, push it back in, repair the defect with a mesh.
Okay. Prof. Rao?
I think this is 6 years. This is 6 years. 6 months. You've had problem for 6 months. So, but it has eroded. Again, probably because of poor quality tissues. So I think the tissues are going to be pretty poor when you go and try and repair it. I mean, make a new channel. I mean, if you have a look, I mean, you can have a look at a different angle on the MR scan, and you know, where has it come out? Is there tissue that you can actually do like a Mulcahy, but proximally to put it into a new channel? That's a possibility, but otherwise, as you say, it's anchoring the stitch, anchoring the implant with a non-absorbable heavy stitch mid shaft, so it doesn't move. You can actually shorten it a little bit, so it's not all the way down at the perforation site. And then, if he's a fit, healthy patient, no evidence of infection, not diabetic, then you can also put some mesh down there as well to sort of cause a bit of fibrosis to seal up that hole.
Okay, very clear. So it's almost the same approach, closing the defect and trying to prosthesis forward.
Naif, can I have a question? Is the same approach for you? You do approach with that transperinally or penoscrotal? Dr. Ran?
I think it depends on the. I think if your MRI scan shows that perhaps you've had a missed perforation, and most of these perforations are slightly more medial and anterior, then you can just go and repair it perineally. Or of course you can do it. You can go through a new capsule and do a Mulcahy. I mean, it depends how experienced you are, really. I don't think it really makes much difference, but I think if you've got a very old perforation with the tissues, you know, just a huge, great big hole, then you're probably better doing it through a penoscrotal.
Okay.
Very clear. So can we move to, for the sake of time, we have still 2 cases. So can we move to case 11, and can I call Dr. Hamza Sisi and Dr. Sultan Thaqafi? So case number 11 is a 55 years old male, post-malleable penile prosthesis 1 year ago, presented to the ER with a distal external extrusion, as you can see. So Dr. Hamza Sisi, are you there?
نعم السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.
Actually, for this case, I should go. Okay.
Yes.
Actually, for this, in short time. Actually, in this case, I have to remove the prostate out, and they this is one choice, and they keep him in antibiotic and follow up for 3 months in my clinic. And every 1 month, I will do ultrasound for penile. It will be help sometimes for the cavernosal tissue to be more good, and it will help me for reinsert after 3 months. This is one way. The other way, I have you have to do in the same time sloughage with corporoplasty and windsock and reinsert it. But all this depend on to evaluate the skin and to evaluate the penis completely. The third point I want to mention it, I should see the report of the first operation. If the patient is paraplegic, if the patient is has Peyronie's, if the patient has any, neurological problems, and the neuropathy degree. Okay, this is my opinion.
Thank you.
Thank you.
Dr. Sultan Al-Thaqafi, are you there?
Yes. Do you hear me?
Yes, please. We can hear you.
Hello?
Go ahead. Yes, go ahead.
Okay. First of all, thank you for all of you. I think my approach, like Dr. Hamza, removal of ending cylinder, and according to if there's infections or this extrusion, the infection or extrusion during the because of the pressure to the tip of the carburetor of the infection. So I will with antibiotics, I leave one cylinder in the contralateral, and with discharging with antibiotics, and come later on for and assess him, because one cylinder can do intercourse successfully and with satisfaction. The other things, if this pressure as Dr. Sisi, he said that is paraplegic, he's diabetic, and this erosion due to pressure. So I will go with the same selfage with Mulcahy with the corporoplasty with the rerouting Mulcahy, or with patchy grafting with either synthetic or allograft or autograft. The other things which I mentioned also as may I will use later on if the with the Dr. Osama Sha'ir's procedure that is which is to the problem in the tip of the carpora. The tip of the carpora is thin more than the proximal or the mid shaft. So if you do Mulcahy or the patching grafting with the synthetic graft or autograft, we will not solving the tip, the problem. So Dr. Osama Sha'ir, he did that. He report for the what's called the partial assembly with the double bristing, with the closure of that area. So the pressure will be on the tissue itself, not on the suture line. So this is my approach.
Excellent. Thank you so much, Dr. Sultan. So the Prof. Ralph, what would you do in this case?
I would just pull the implant out in the ER and ask the patient to look away, and you can just take it out there and then without any anesthetic. Send him home, possibly with a catheter. I'll have a look at the urethra, and hopefully it'll all fibrose down, and then we can come back in and put another one.
You've taken those from my mouth, actually. Prof. Sha'ir, would you do the same? Take it in the clinic, let him come again later on?
Make sure the rear tip extender comes out.
Yeah, we'll definitely we'll remove it and make sure that we have taken the rear tip extender as well. I would try and reinforce, as our dear doctor here said, I would try to reinforce the tip at this occasion, if I can, by partial disassembly and double grafting, or just divert and let it heal. Yeah, so I agree.
Thank you so
I
much.
have final comment. I
Yes.
totally agree. I've seen some patient taken to the OR with that condition, which is not necessary. It can be removed easily from the in the clinic or in the emergency. The point that's made by Dr. Hamza, that we, after removing the prosthesis, to put tadalafil 5 like Eurox, put patient on it to maintain the vascularity for 3 months. I think should be taken into consideration how to maintain the corporal healthy till you come to the next prosthesis, whether by vacuum device or by Herox 5 milligram, tadalafil 5 or something. We move to the next case, please.
Yeah. So the last case, number 12, is a very interesting cases actually. This is the most difficult one, I think. So Dr. Fahad al-Mashar, Dr. Mohammed Habbous, Dr. Fahad al-Mashar from Mohammed Abdulaziz Hospital, our famous neurologist, Dr. Mohammed Habbous. So case number 12, so 65 years old male, case of prostate cancer, prostatectomies, post-malleable prosthesis. This picture is after 1 year. So he's in your clinic and apparently he has difficulty in penetration. So Dr. Fahad Mashab, what would you do?
Bismillah ar-Rahman. Good evening, everyone. I'm just concerned about the history. Was he like this since the beginning, or is it just recently that he developed this sort of devil's horn sort of picture?
Since he started the intercourse 1 month after surgery.
Right. So, I mean, there's a problem with the way this prosthesis has been put in the first place. There's no doubt about this. I would be concerned about the way the operating surgeon had done his dilatation and sizing up of the corpora initially. I would really want to know what the area looks like inside, and obviously this has not been sized properly. So this patient obviously, had this been a case where there was a droopy glans and a chance of glanspexy, that could have been entertained. But since the glans sort of drops down proximally and the protrusion is ventrally, then he would need to be counseled for a redo procedure where the prosthesis or exploration has to be entertained, the prosthetic cylinders chucked out, taken out, proper redilatation, proper sizing, done and reinsertion of another malleable prosthesis. Obviously, I understand he's a cancer patient, so he's got an abdominal surgery on his belly. Is it not true?
Yes, prostatectomy.
So I would put another malleable, but making sure that the proper dilatation, the proper channel, proper sizing is done in the second instance, of course, which is classical teaching, covering him with antibiotics and all that good stuff. So this would be my approach in this case.
Okay. So Dr. Habbouz?
Yes. For me, I would explore, do a penile, ventral penile, distal penile incision or bilateral subcoronal to explore both steps of corpora. I think we need to do a new channel or a new by sharp dissection. Other than this, to make a new channel or a new way to put the tube. And I would advise, if the patient agrees, to put inflatable, maybe 2 pieces Ambicore, if there is any problem with the reservoir, or if there is no problem with the reservoir, we can do 3 pieces. This would be fine, because malleable will not be advisable in such case. So I will make again a 2 channel in every corpora and in every side, subcoronal, and I will dissect and find a new way other than this. And maybe we need to put some mesh cap over in the distal way over the tip of the prosthesis, and make sure that this is not a movable glands, because this could be one of the options.
Okay, excellent. So, so what do you think, Prof. Shuair?
Yeah. Well, what caused it, we can debate about it, but how we handle it, there are 2 ways. There's the simple way, and there's the much less simple way. So there's the glanspexy, and there's the replacement with the proper dilatation. I'm much inclined to do the replacement, but if the patient is happy with the length, he doesn't mind the length, then I would go for the safer option, which is the glanspexy.
Okay, Prof. Ralph?
I think you assess the patient. This is a floppy glans. You assess the patient with an MR scan and see where the implants are. Usually a glans that is floppy in a dorsal direction is because the cylinders are too long. It certainly doesn't look like they're too short. When you've got the glans completely off, you can actually see the cylinders on one of those pictures probably are too long. So an MR scan to see this, what this, where the position is in the corpora, and probably shorten the cylinders and do a glanspexy.
Very clear. Prof. Gattal, what do you think? I think the time is there. So what do you think?
For the sake of time, we're going to add one more case, and then for time and for the sake of your time as well. So the last case will be case number 13. We'll put it now, and then we'll terminate. And we have with us Dr. Saleh bin Saleh and Dr. Ahmad Rajah. This is a 28-year-old male patient, brittle diabetic, insulin dependent. He have a very young wife, just married recently, and 3 months he have the prosthesis inserted, and he have eroded pump through the scrotal skin. He's very keen to continue section intercourse because of his young wife, and very concerned about his penile length. So, Dr. Saleh, if you would like to continue. Dr. Saleh with us? Dr. Ahmad?
Yes, with you. Do you hear me?
Your opinion, please.
Yes, in this situation, actually, my decision depends on certain clinical aspects, actually. First, presence of systemic manifestation of infection, scrotal tissue condition
the third is the presence of penile shaft tenderness or pain, and actually the blood sugar status. How is his hemoglobin A1C? So we have three options, to be honest. Either to explant the whole device and replace it later on, which is a valid option here. Second option, to explant the whole device and to insert malleable prosthesis utilizing Malkay protocol, and to put drain and to cover him with antibiotic. Third options, I'm not with it, is to replace the whole device with the inflatable device, but not suitable because, as I see here, the scrotal condition is too bad, and there is a lot of pus coming out. So if patient insisting to continue sexual activity and he want to preserve the penile length, we have to do better counseling for him to replace it with the malleable, given that there is no penile tenderness, there is no penile pain, and there is no systemic manifestation of infection, and his hemoglobin A1C is stable. So I can, if these conditions are under control, so I can put a malleable prosthesis using Malkay protocol and to cover him with antibiotic. Otherwise, to remove the whole device.
Okay, Professor Saleh with us? Maybe not with us. Maybe Professor Ralph will tell us what you do with that. Agree with Ahmad or no?
I think I think in this situation, because of his young age and his desire to get back to having sex, take everything out and just put do a salvage and put a malleable implant in.
Okay, Dr.
Come
Shair?
back another day, put an inflatable.
Professor Shair? Prof. Shair, yeah.
His camera is here, maybe the internet connection.
Okay, Professor Naif, what you're going to do?
This is my actually this is my case. So this guy was referred to me from one of our dear andrologists actually, and this guy came to me. He has a short penis, and he has pieces that I haven't seen before. It's from Ukraine. I think it's Ukrainian brand of prosthesis, and the bone was so superficial. So and he was refusing totally to just take everything out. I told him classical teaching, what we should do is this, you are type 1 diabetes. But this is one of the cases that you know that you did a mistake after the surgery, because what he has been promised is that, look, I'm going to take this, and if I see that your corpus has pus inside it or it's also infected, I'm going to take everything out. So he was consented for that. However, when we went in, it was a clean corpora. So we malleable prosthesis on, but actually at 2-3 days after the surgery, he had penile swelling, and then he had small cracks on the skin because of the swelling after it has shrunk, and then he had gangrene of those cracks, not of the prosthesis itself. And then this guy tells you, look, oh yeah, I remember 2 years ago I had the Fournier gangrene of my perineum, and look at the graft here. And he discovered things after the surgery. But anyway, he did fine. He only got infected of the cracks on the skin, and we could save him. He's, I think, my fellows knows him, and he's fine. Luckily enough, he's fine. So.
Okay, Naif, thank you. Professor Ralph, thank you very much. Professor Shair, thank you very much. All our debaters, we thank you very much for your commitment, for your excellent discussion of the cases. Sure, everybody watched this webinar, had learned something new, had deepened his experience with dealing with this case and listening to our great moderators as well. I wish to thank everybody, and I hope you have a very pleasant night, and we'll see you in the next webinar. I wish to thank as well Tabuk Company for their excellent support, both on their organization and for providing us with their Thank you, everybody, and have a good night. Bye-bye.
Thank you.
Have a good evening, everybody. Thank you so much.